it's actually lower. It's actually, the numbers who died are actually, the representation is lower than in the population. So it's just because the numbers, because of the total numbers are high, it looks high, but actually representatively, they're actually lower represent. Does that make sense? So but again, I mean, absolutely. I think, if we focus on what those determinants of health and those wider societal issues, I think we can address this. We can address, what's going on in the virtual school. There's a huge number of other areas that we can support, and my colleagues can talk in a minute about mental health as well, and I'm sure it's going to be very similar.
Thank you.
Thank you, Councillor. Councillor Begum.
Thank you, Chair. I just have one point that I'd like a bit more clarity on. So it's on your page 16, on our page 80, where you've got thematic panels, and it says on your second sentence that additional neonatal themed panels for the year 24-25 to address a backlog. So are we saying that even though we've got these figures in front of us, there is an additional set of child deaths that are still being looked at?
Yes, and thank you for picking that up, because that isn't actually picked up specifically in here, and I'm glad I can address that. So yes, because of COVID, so if you're going back a long way, we weren't able, there was a big delay in the system, and when you can imagine, we probably had about 2 years where things just took a long time to get back to normal, and that has led to quite a large backlog of cases. So there are cases where the child has died, where we are going through the process, as Councillor Keane talked about earlier, with hospital, with police, etc. There's lots of different organisations involved. So we do have a backlog. So what that has meant was we picked up, when we talked about the neonatal panels, it was made a decision that we would focus on those neonatal panels because of getting the right clinicians into the meeting. It made sense to have them all together rather than having them come to lots of different meetings. They just have to come to one. So yeah, it was a pragmatic decision, but actually it's worked quite well to just have neonatal themed meetings. And there still is a backlog, and we are continuing to work through that.
Do we know what that backlog looks like, and do we know how long it will be till we kind of get those figures? Because the last thing you want is a report that comes and then, yes, you've noted that there is a backlog, but obviously it's still not a true representation of what's actually happening.
Yes, so what I'd like to just, in the report, there are 2 sets of figures. One is the number of cases we looked at this year, but as well as that, we did look at the number of deaths. So we haven't been able to look at the modifiable factors there. So hopefully you're reassured that we are still identifying and they are still reported on. So we're not going to, if there are numbers are increasing, we would be aware of that. There are really complex and multivariate reasons why a case hasn't come, and we have regular meetings to look at that. And so there is still a backlog. We do look at it regularly. We do try to bring as many cases forward as we can, but we have to let some processes run, and sometimes specifically in cases, unfortunately, where it's been very complex, if there's been police involved, it takes a long time.
Councillor Keynes.
Actually, following on from what Councillor Bain was saying, what was, you nearly answered the question, what's a modifiable factor?
Modifiable factors. So modifiable factors, and I've kind of tried to not have to define it because it's so difficult to define, and it means different things to different people. But I think where we sit in the CDOP is that if there was something that an intervention that the system could have made that wasn't, that could have changed the outcome, then that counts as a modifiable factor. If the system did everything it could and that child still died, sometimes we have to say, that isn't modifiable. There is nothing that the system could have done to change that outcome. But if there are things the system could have done, and that's anyone within the system, then that's a modifiable factor.
Right. My next question is the panel above that, liaison with LA housing teams. It's fairly easy to deal with the local authority housing problem with mould, etc. How do we go around dealing with the private rental market?
I mean, You're absolutely right. So we have spent a lot of time talking with our housing colleagues, and I'm pretty sure that we've been. I remember coming to this group and talking about housing issues before. It is a very difficult situation. Our housing team do work very hard, but unfortunately, with private rented landlords, it is quite difficult. So we do work with the housing team, and the housing team actually have become almost regular visitors to our CDOP in an unfortunate way, because so many of the modifiable factors are linked to poor housing and behaviours that are occurring in housing that we feel housing need to take more responsibility, not take responsibility for, but they have an opportunity to make a difference. So we are doing what we can. We are working with the housing team. They are, as I say, regularly attending, but I can't agree with you more. It is very difficult to regulate private landlords.
Yeah, we're never going to solve the problem of private landlords until we hang them from the nearest lamppost. I never said that. Yes, we can deal with the local authority. Do you put in a report to the local authority, and how quick does the local authority respond to looking at this problem?
Are you talking about in specific cases, or are you talking generally?
Yeah, well, both. Go on.
So with regard to mould, the issue that did come up around mould, we then went, when it came up that there was a child died and there was a modifiable factor that linked, so we're not saying the child death was directly related to the mould, but it was a respiratory issue and there was mould in the property. So we've been able to then work with that particular family and get them, in housing that is appropriate for them. So on an individual level, there are things that we can do. But obviously, this is only once the CDOT process has gone through, or not even the CDOT process, once that child has died. With the more general approach, it's quite hard to kind of answer that from a general approach. But, we within the local authority housing, we've done a lot of work to reduce that. But I think within the private, I suppose I'm asking maybe just to repeat the question, because I feel like I'm struggling to answer the other way that you asked the question.
Well, what I really asked is how long does it take the local authority to respond to?
We are part of the local authority, so we are. I'm local authority. We're all part of the local authority, so it's normally quite quick because we are closely linked to the local authority. We are the local authority. So they will get back to us. They will get back to us. Yeah, they will get back to us. Yeah. They will get back to us. We don't normally have an issue with them getting back to us. We'll ask the information in one meeting. They will get back to us by the next meeting.
Councillor Bacon, was your question a supplementary to Councillor Keen's?
Yeah.
I'll let you go first then and then come back to Councillor Hussain.
Thank you. Just basically going on what Councillor Keynes is saying in terms of mould, would that, or if a family presented sort of multiple issues, took the child to the hospital, doctor, whatever, and they were constantly showing that there was respiratory issues, obviously I'm thinking of in terms of multi-agency working and so on, would that not trigger sort of the Section 17 of the Children's Act in terms of a child in need? Could we not identify that child as a child in need and therefore intervene before, obviously, a death occurs?
So the CDOP obviously only picks up after a death, and I'm going to look across, and I think that would be work between children's services and housing. Yeah.
Okay.
But yes, it does happen. Yeah.
Okay.
Because even though it is maybe private sector housing, the local authority also has some responsibility in working with those landlords to ensure that actually they provide housing to a good standard. So it is actually as a local authority putting that challenge forward.
Thank you, that's reassuring.
Thank you, Councillor Hussain.
Yeah, I think you all recently had a paper in licensing. Once the licensing comes, the council will be able to prosecute as well. They will have resources to be able to do that. My question really is more of a comment really. On page 16 on the top, on your 16 and mine 80, is close relative marriages, and it's a very sensitive subject, but it needs to be highlighted because it is something that community needs to be, and you are a public health, you have a statutory duty to be able to highlight that issue, that it is a problem no matter how sensitive it is or whoever it upsets. I'm
Yep.
one of that part of that community, but I would speak as loudly as possible, because that is one thing that we need to be more and more highlighting to the community, that that is a problem. It's also a problem in special needs. The children in that particular group, are more of them are born with some sort of, special needs thing. So I think it isn't just the deaths, it is also other factors that we need to be very robust and being saying that. It may upset few people, but it's my elected member duty to highlight that issue.
I really appreciate that, because we actually do spend we have a programme in Luton. We are one of 10 local authorities in England that have been funded to do work around supporting genetics and close relative marriage. As I say, we have a whole programme addressing this, and I see this it does come up on a not irregular occurrence, but I absolutely, when you're picking up about the sensitivities, we absolutely do need to be very sensitive to those cultural issues. So we are very well aware. We have a service that picks that. The aim is that any parent, where they have a child who has died linked to a genetic condition, linked to close relative marriage, we have a genetic service, a genomic service that will support them going forward.
Are there any other questions? Are we all happy for the recommendations to go through? Thank you. Just one question, Councillor Hussain, with your question, the officer did say they were happy to come back and do an infant and maternal death report. Is that something you're actually wanting? Would you be happy to do that?
Yes, that's fine. Then I sit on the pre-meet for this, so we'll schedule it in. That's fine.
Thank you. Can you make a note of that, please? For your time. Thank you. Okay, so are we okay to go on to item 2? Yep. Lovely. So it'd be in the separate pack that we got in our packs. We've got item number 10, which is on page 1 of 75, the Luton All-Age Collaborative Mental Health Strategy. Would the officer now please like to give her report?
Thank you. Hello everybody, my name's Nicola Ainsworth. I'm the other joint Acting Director of Public Health. So the papers that I've submitted for you to scrutinise are on the, as you say, the all-age Luton Collaborative Mental Health Strategy. This has been a strategy that has been 2 years plus in the making. So hopefully we're getting to the very final stages of being able to sign it off. The strategy has a vision where Luton is a community where I feel listened to, believed, understood and supported to become the person I want to be. So it's a very person-centred focus on mental health. The main 2 priorities are around improving prevention, around poor and worsening mental health, so making sure everybody stays in good mental health as much as possible, and then improving access to services for all ages. Those are the 2 kind of main goals we're aiming at, and it's underpinned by 3 key areas of integration across services, having good quality services, and people having a good experience when they are in contact with services. So originally the strategy was 2 separate ones, one for children and young people and one for adults. But I think a decision a little while ago was made to bring them together. It was felt to be appropriate, especially as we need to consider the issue of people who transition between children's services and adult mental health services. We've been working, whilst it's been in development for a long time, we have been working on implementing it at the same time. The action plan that you've had as an appendix I'd just like to point out, it is a working document. It's constantly changing and evolving, and we're working closely with all partners on this. The prevention work stream is led by Public Health. The work stream around access to children and young people services is led by ELFT, as is the the East London Foundation Trust, as is the Access for adult services, and then the transition services is led within children's services here at the council. So we're developing a dashboard of outcomes at the moment. It's a nice interactive dashboard. We're building it at the moment as we speak to monitor the impact of this strategy. It's a long-term strategy, so we'll be monitoring it over many years. And you'll see from the recent consultation work that we've done that there's clear support amongst adults and children and young people for the main goals of prevention, access, integration, quality and experience. So you'll see the strategy hasn't changed a great deal from when it was published on the website. It is available on our Luton Council website at the moment. I've tracked the changes in. Apologies for leaving in the comments boxes. Those should have come out. But you'll see the tracking where it has actually changed a little bit. But I'm very open to any questions or thoughts that you have to improve and make this the best strategy that we can have for Luton. Thank you.
Councillor Skeppelhorn.
Thank you, Chair. Given that we live in an era of increasing deprivation and both national and international crises, as a child of the 60s who grew up in the Cold War, the impact on young people of what they hear in the news, what they perceive within their own families, must be something that brings an increase to their mental health issues. But the problem I perceive here, and it's on page 6 of your report, page 10 of the, that youngsters of ethnic backgrounds are less likely to access mental health support. Part of that, I think, and this is just my personal opinion, is that families of those were always stronger in that their wider families are close together. So they rely perhaps on parents and grandparents and aunts and uncles for that support. But it isn't always available. And we need to get into those families to understand that there are services that can help them. And that's, I mean, I work with people of all ethnicities, and it's still that thing that we used to have perhaps back in the 60s in white families, that parents and grandparents were close and close by and could be relied upon. That's dissipated because of the spread of movement. It's beginning to come into those ethnic communities as they begin to spread. But there has to be a way to get to those young people to make sure they are aware that we have facilities to assist them, because they see the same things that everybody else does, and it's frightening out there. And you need people around you to be able to help. And if you haven't gossip because you don't have the close-knit family that perhaps you used to have. They need to know where, so we need to be able to get into those community leaders to let them know that there is help and support out there.
Absolutely, and a big part of the interventions or action plans are to spread the message as far and as wide as possible in an accessible way, in an appropriate way. I also think stigma is still an issue for lots of communities, and addressing that is something that is a major part of the prevention work stream, that talking about mental health and saying, how are you really, and being open and honest about it with people, we still have a way to go on that. So yes, I absolutely agree. We need to get into those communities. We plan. That's what we're wanting to do. So I'll make sure if you don't feel it's reflected enough in the action plan, I'll make sure it is. I'll make sure that's a really key part of it. So thank you for that.
Mental health perspective, company I work for a government department, and they are focusing a lot on making sure that managers keep an eye on how people are, but colleagues talk to each other. Probably need to get that into schools somehow.
Absolutely, and there is lots of work in schools around mental health, but I think we can always do more in this space. Absolutely, yeah.
Councillor Hussain?
Can I ask you, relevant to that stigma and that with certain communities, can I ask you, in terms of your page 22 and mine is page 26, in terms of the sport in school to improve the mental health of staff and the pupils, is there a sufficient CAMH people to be able to support the school, or is it just the link worker reports it and then the appointment with some child mental health psychologist takes months, and maybe by that time they've gone through the school, and is there a sufficient resources there now in Luton? We want to be satisfied that we have got people that can see them when the needs arises, yeah?
I see what you mean. So in part you're talking about what resources schools have at the moment. Is it enough? And then if they need to refer into mental health services. So I know children and adolescent mental health services have teams that work with schools, don't they?
And in schools.
And in schools as well. So there's that support there. Arguing whether we have enough at the moment, I'd be interested in your opinion as to whether you feel we have enough.
I've actually seen an increase over the last couple of years, and we've had an awful lot of support from the mental health support team, very tangibly as well, coming into school, delivering assemblies, and they've been very much a useful touch point where we've had individual cases we've wanted support with. So I can only commend the support we've received, and I've definitely needed noticed an uptick in the support that we've received.
Well, that's really good to hear. But as always, we want to keep making sure that that's the case and increasing it as much as we can. Yeah.
The reason I'm saying since the COVID, general data is that there's an increase in number of children having that in mental health problems, and also the other data is that my other role with Terry was in the magistrate's court. Number of children that come into that side of the court do have a mental health, but never had any support at all. Right the way through, and of course courts can't give them that support. So I think it's taken into account that particularly those that come into care, do they get any assessment at the beginning when they come into care?
That's a very good question. I don't have the answer to that. I can go away and find out and come back.
Looked after children.
Do they have an assessment around mental health needs?
Not specifically around mental health, but they do have health assessments because they are looked after children. I think in terms of mental health presentation, I have got it on. I've just got a very soft voice. It is on. I think one of the things to note about children who are looked after is that sometimes those mental health issues don't present themselves until after the child's been in care for quite some time. So, you know, there's value, but they have health assessments at the point that they come into care, but not specifically mental health assessments.
The reason I'm saying that you know, from experience, that most of these children have experienced horrific, not only domestic violence, but other things that within the family. Yeah, so that would have an impact if a child has suffered at a very young age, till they come into care, maybe 3 to 4 years, and the damage that's been done to them would make it easier for the foster care to be able to understand the need of that child, because it's very difficult to deal with a child who has suffered such a horrific incident in their lifetime. So I think this will be a positive thing that I think social worker and yourselves need to take that it is done right at the beginning, rather than when the foster care, it fails, you know, the placement fails, and then we start looking for all over the country for a placement. Yeah?
I understand. Yeah, and the point that you make about the trauma that these children have suffered is completely correct. I think formal mental health assessments, though, in the regard that we're talking about here, if you think